Welcome back to the podcast. In this episode, we're going to be speaking with the author of Designing for Healthcare, the Human-Centered Approach, Craig Joseph. So he joins us to talk and discuss about design processes, workflows, operations, and technologies around person-to-person interaction, which fundamentally lies at the heart of healthcare and indeed human factors. So Craig states that currently chronic disease management, medical bankruptcy, and equitable outcome are just a few areas that need major overhaul within healthcare. So Craig posits that human-centered approach to managing health, preventing disease, and indeed treating illness can create more effective and indeed equitable systems. So within the conversation, we're going to examine the inbuilt biases that we, indeed all of us, can carry through to our decision making, as well as 6 key principles that Craig advocates for enabling safer patient care. Welcome to the podcast, Craig.
Well, thank you for having me. It's a pleasure. And I think the only aspects of healthcare we really need to fix are all of them.
Indeed,
So
indeed. But
there's some
listen,
work ahead.
there is, absolutely is. I think before we kick off with the formal questions, Craig, could you maybe speak to your background just for listeners and indeed viewers?
Sure. So I'm a pediatrician by training, which in the U.S. is kind of a primary care, a little different than in most of Europe. So see kids up to 18 or 19, generally till college age. I practiced primary care peds in the Detroit area for about 9 years before actually moving to the dark side and going to work for an electronic health record vendor. Did that. That was Epic, a big vendor internationally now, and learned a lot. And after that, started working on the hospital side. So became the chief medical information officer for a number of hospital systems around the country. Some running Epic, some running one of their major competitors, Cerner, now called Oracle Health. My main job when my children asked me when they were younger and I was going on a trip, they said, "Daddy, what are you going to do?" And I said, "Daddy's going to a far off city to get yelled at by doctors um, who were generally unhappy about the technology that they were being forced to use, sometimes reasonably, sometimes not so reasonably." And did that for a while. And now for about the last 4 years, I've been working for Nordic Global, a consulting company that we deal with healthcare and a lot of technology aspects of healthcare and how hospitals and healthcare systems are dealing with those things.
So I'm a big believer actually in human factors engineering and actually systems approach and how we approach. And within the conversation, we'll certainly get to that as to some of the ways we can optimize workflows and indeed make, like you said, patients' lives safer in the process. Um, but I think my first real question would be, so what prompted you to write this book, Designing for Healthcare?
Yeah, that's a good question. My co-author and I, doing our job as consultants and kind of working across the country, kind of ran into the same problems over and over again. That people who were designing some of these technologies and workflows for physicians and nurses and receptionists and billers throughout the healthcare world, we're often kind of ignoring the way that humans interact, right? And so saying like, "Oh, well, I think it should be done this way," or "the chief of cardiology wants it done that way," yet that person doesn't actually do the work often, or has maybe kind of some strange way of dealing with certain sorts of data that it really appeals to them to see it in this format, but almost all of us would rather see it in a different format. And so I got asked questions by our clients. "Hey, why are people not doing what we want them to do? Why are doctors not ordering the medications that we think are the best? Why are nurses not filling out some of this documentation? Why are we not collecting copays here in the US on a regular basis?" And oftentimes, well, we made it difficult. We made it difficult to do that thing. And then we wonder why people don't do it. And so it was really kind of just to get the message out. There's no cutting edge ideas in this book, I don't think. I think it's just basically trying to expose senior leadership to the idea that there are ways that humans work and function. And if you ask folks to kind of work in those directions, good things happen. And if you ask folks to work in an opposite direction, there's a lot of friction and it's unnecessary, and it might make you and your employees want to pull their hair out. And for some of us, that's a bad thing.
Yeah, indeed. Well, listen, the book is a fantastic and really fascinating read, actually, and we'll put links in the show notes to the book. You speak quite candidly and quite clearly to bias within the book, and I wondered, Craig, if we could just really unpack how much of our bias gets in the way of clear decision making, and maybe if you could just also just speak to some of the prevailing biases that we carry with us.
Yeah, well, there's been a lot of work done on some of the human biases. I think oftentimes the most obvious one, especially for physicians, is we go by what we've seen, maybe not, but what the numbers tell us. And so if I've seen three people in the last 5 years who have this very rare disease, to me that seems like a much more common problem. Even though I know it's rare and I know that most doctors maybe never see it, but I've seen three. And so if someone comes to me with that kind of with an issue that might be going in that direction that requires a big workup or a lot of tests, I might actually move forward in that direction, which is not really the recommendation. And so what we're exposed to colors our world, and that's certainly a bias. It's not a prejudice, but it's just the way that humans think. We also are worried. We also have sometimes hard time thinking about the distant future, and we're much more focused on what happened yesterday and what's going to happen next week. And so, certainly I was talking about a physician with a bias, but patients also have the same problem or same sorts of problems. Like, hey, you should probably be eating more salad and less red meat, and maybe get rid of some of those trans fats because your risk of dying of a heart attack in 10 years is much higher than it should be. Well, that's hard when I'm sitting in front of a piece of steak tonight to think about what my risk factor might be in 10 years. And so that inability for us to really plan for the far off future, it's not that we can't do it. It's just that that's not the way our brains evolved, right? We evolved as wild animals, so to speak, and we're worried about the environment right around us, and that's good because that helps you get to the next day. But in modern society, where most of us aren't really worried about surviving to the next day, that a dinosaur is going to eat us, we need to kind of evolve as much as we can, or at least acknowledge some of these biases that we naturally have, and that we want to kind of incorporate into our life. One way of thinking about this, using a non-medical view, and one of the things that we talk about as a basic principle, is thinking about opting in for at least in the US for retirement, putting money away. So some countries, that automatically happens for you. That's partly in the US. We get a little bit of money taken out of our account, out of our checks every week, whether we want to or not. Federal government takes that, and hopefully they do something good with it. And when we retire, it'll be there for us, maybe. But it's really good practice for you to put more money away that you can control. And when you start a new job, usually you'd have to opt in for that. So the employer will say, hey, we have a retirement account. We'll actually chip in a little. So if you put in $5, we'll put in a buck or two. That's a pretty good deal. You want to sign up? And when they've done that, which is a pretty good deal, there are tax benefits to it. About 65% of people would sign up for that, maybe a little less, between 60 and 65%. And then there was a paper where they said, well, let's turn this on its head. Let's, when we get a new employee, say, we're going to sign you up for this unless you tell us you don't want to do it. We're going to opt you out, right? And most people kind of go along with whatever's presented to them. And so we'll not take that energy to kind of look into it and say, well, I don't know if I really want to do this or not. In the same way that many didn't opt in and sign up for it, many don't opt out. And they got into the high 80s with the percentage of people who were ultimately signed up for that retirement plan by requiring them to tell you that they didn't want to do it. Because most of them probably did want to do it, just never got around to it. Again, another one of the biases of humans, to just say like, well, if you've checked the box for me, Even if I'm capable of unchecking it, I'm probably not going to do it most of the time. And so that default choice is the one that I'm going to make. And if you incorporate some of these biases or the ways our brain works into workflow, in this case, you wanted people to sign up for the retirement account. You thought it was good for them. Um, Make it easy for them to do that. And by that I mean default that in. It's a whole area of study called choice architecture, where how you design that decision helps influence what the decision is going to be.
It's really interesting, actually, Craig. And there's been a lot of human factors workflows around this, as you say, and actually making it harder to indeed opt out, but also reducing friction to make better decisions in the work architecture, which is and safer decisions actually as well. And so let's go there because the book does denote six key principles and fundamentals of patient safety. I mean, we're all showing up as clinicians really to provide safe patient care. Could you maybe speak to these six principles that you denote within the book?
Sure. So the first one I've kind of alluded to already. It's make it easy to do the right thing.
Yeah.
And again, that you brought up that word friction, which is exactly what we want to talk about. So make it easy to do the right thing. I'm putting together a slide for a talk I'm going to be doing later this month, and I'm trying to be humorous and get a point across. And I say, make it easy to do the right thing. Step one, figure out what the right thing is. Step two, make it easy to do that. And I assure you, step two is often the easiest part of the work. Most of the work is what's supposed to happen. And so again, thinking in healthcare, thinking about a patient admitted for community acquired pneumonia, we want we probably the hospital administration, probably the infectious disease experts, want physicians to choose the right antibiotic when they admit a patient for community acquired pneumonia. And we know in the local community what the bacteria and viruses that you're dealing with are. And so the infectious disease experts can kind of say like, well, this antibiotic covers the most of the bacteria that we see, and it's the cheapest. And so we'll probably get the most bang for our buck with this. That is now the right thing to do. And now the question is, okay, well, how do we make it easy to do that? Well, in an electronic health record, there are often things called order sets, right? Collections of orders, and physicians often use them, or providers use them in different ways. But one way is, well, I just want to get these orders in quickly. I mentioned if you put that antibiotic or those antibiotics that you want folks to use and you default them in so that when the physician opens up the order set, that antibiotic is checked. Now, does that mean the physician has to do that? No. They could uncheck that box. They could not use the order set. There are lots of options there. But we want it to be easy to do the right thing. Once you figure out what the right thing is, whether it's signing up for a retirement account or picking an antibiotic or the right medication, make it easy to do that. And I sometimes add to that, and I add to that sentence, and slightly more difficult to do the wrong thing. And so sometimes, and again, it sounds silly, but sometimes the wrong thing is the right thing, right? Hey, I know you want me to put this patient on this antibiotic, but I already had them on that at home, and they're getting worse with their pneumonia. So clearly, the right thing is not to put them on this antibiotic that we already know is not working very well. And so, yeah, sure, you should have the ability to opt out of these things. We talked about choice architecture. That's really where this is. Again, lots of examples. Behind me is the book Nudge. Tons of examples of nudging people in the right direction, be it at a cafeteria where you put the healthier food first in the line that people are going to walk, and the desserts maybe at the end, where you give people smaller trays so they can't fit as many plates on the tray, so that they'll be required, if they want to have more food, to go back for more trips. Well, that's fine. You can go back as many times as you want, but we know that they'll fill up on the healthier stuff. Not everyone, not all the time, but statistically speaking, that's what the studies have shown. So we're making it easy for you to do the right thing. The right thing is to eat a smaller amount of healthier food. And so that's the work that we do. But at the key thing, and where a lot of people start to get upset, if they're going to get upset, is, well, hey, I have the choice. I'm the patient, I'm the physician, I'm the nurse, I should have free choice. Well, you absolutely do. You can go back and get as much food as you want, or you can totally walk by the healthy food and go right to the dessert if you want. We just know that most of the time you're probably not going to do that. And most of the time, those are probably good decisions for you and for society. So make it easy to do the right thing. The second thing is gross. I just like to say it's just gross. But that's an acronym for getting rid of stupid stuff. When we were writing the book, we had some lawyers looking at it, and one of them was like, you can't call this chapter gross. You can't. Are you saying that some of our clients are gross? And I replied with, let me show you the New England Journal of Medicine article entitled "Getting Rid of Stupid Stuff." And it was a great article from not too long ago, 2018. And the chief medical information officer at Hawaii Pacific Health, the hospital system in Hawaii, decided to do this insane thing. She asked people what was broken, what was wrong with the electronic health record that their doctors and nurses and staff were using. And a lot of us do those kinds of things, ask people what's wrong. But the key thing that she changed is she actually did something about it. So she was transparent about how the answers that she got, or the things that people pointed out, a lot of them were really oversights. One of them was asking nurses to document on the status of the umbilicus in a 6-month-old for a checkup, right? So the cord, you cut the cord for the first few days. I'm a pediatrician. This seems natural to me, but maybe some people don't know. First few days, sometimes it oozes a little bit, the umbilical stump, and you have to watch it, make sure it's not getting infected. Sometimes we have to put some cautery on it to make it to help it, encourage it to stop oozing and to dry up and fall off. Makes complete sense for a 2-day-old, or maybe even a 1-week-old, to ask the nurse to document on that status. A 6-month-old, if a 6-month-old still has an umbilical stump, it's not good. It's not good. That was just a mistake. But that nurse had to click a box every time that they saw a 6-month-old, or prepped a 6-month-old for a checkup. And it's not a time waster per se. It's just one click, but it's over and over, and then you add it to the 20 other one clicks that they have to do for every patient, and it becomes it takes time, A, and B, it's a moral hazard. It makes you just think, like, what am I even doing here? Are the people that required me to use these tools know anything about the job that I do or the patients that I help? And so, getting rid of those things, identifying them, even small, little, seemingly insignificant things, are big, big wins. Uh, in the book, I tell the story of a doctor who I was working with, or probably more accurately for. And I said to him, "Hey, we just added this new module, like gives you all kinds of new functionality, really solves this big problem that you were doing on paper, and now we can just bring it into the electronic world. There's a lot of work, costs a lot of money. How's that working out for you?" And this was my opportunity to give him an opportunity to thank me for my hard work and brilliance. And in fact, he says, yeah, that's okay. But I really wanted to thank you for that big improvement you made in that documentation template I use every day. And I was like, well, what was that? It was, oh, well, the third sentence in the second paragraph had 2 periods at the end of it. And every time, and I use this thing, 10 times a day. So every time I had to go find those 2 periods and delete one of the periods, because, I'm anal retentive and I don't like 2 periods at the end of a sentence. Um, and that was a fix that you can imagine took 35 seconds. That was easy and didn't cost anyone any money. And that's what this guy remembered. That's what he wanted to thank me for, not the fact that we spent millions of dollars on this expensive module. And that really kind of hit home for me, that it's these little things, it's these little pebbles in your shoe, that if we can get rid of, really, you're not even asking me for new shoes. You just want that pebble out of your sock, and it makes a big difference. Third thing, start with the end in mind. And so oftentimes, especially when we move from paper or non-technical devices or tools to more technical ones, so oftentimes we're just trying to recreate the workflow or concepts that we already have. And that sometimes is good, but oftentimes that just doesn't make any sense. And so if you have a paper form and you're like, okay, well, we need to, and as you can imagine, I've had this question posed to me. Hey, I have this paper form. I need to turn it into, we need to fix it and put it into the electronic health record, make it electronic. And I'm like, great, terrific. What's the point of the form? Well, it's a form that we need for you to turn into something to put in the electronic health record. And I'm like, no, I understand that, but like, what information is there? Is that information not somewhere else? Is it who's filling out this form? Are they the right person to fill out this form? Um, and a significant amount of the time, you find out, well, we don't really need that form anymore. A, maybe that form never made sense. B, maybe it made sense 15 years ago, but it doesn't make sense now. Why are we asking a medical assistant or a nurse to ask a patient something when the patient's already told us this via their phone or the kiosk that they use to check in? Um, I don't, I, we're, kind of taking a paper world and trying to put it on to electronic format. Um, I think this is called skeuomorphism when you're talking about design, right? Apple did this at the beginning where they their calendar app looked like a calendar. Things they wanted people to think of them as real world representatives. And so, starting with the end in mind, or your target end user, and then working back from there to try to understand the requirements makes a lot more sense than saying, well, this is what our nurses do in the paper world, so hence now we will transfer that into the electronic world. Doesn't make any sense. Fourth thing, transparency and predictability. Adding transparency and predictability. And what do I mean by that? Well, one of the features of a help desk system that I once used when I was on the vendor side was transparency. I could submit a help desk ticket. Most of us, if we have to call someone or ask someone for help or send an email, we send off the email. We send off the request. Where does it go? Where's it in the queue? Who has it? When should it get back to us? Like, you don't know any of that. And so it's kind of goes into a black hole. And then people say, well, we're really concerned that our clinicians and operations folks don't tell us what's wrong. Well, you might have made it hard to do the right thing. That's the first chapter. Or you're not adding transparency so that people can see where it is. Oh, I see, it's gone. I sent it to Bill, but it looks like I wasn't supposed to send it to Bill. I was supposed to send it to Bob, but Bill forwarded that on instead of telling me, because I don't really care. I just want it to get resolved, and I don't do this every day, and I don't need to learn some of these rules. Predictability, the same kind of idea, though, incorporating the concept that the same thing's going to happen every time. And I give an example of sometimes this is me personally trying to be too smart for my own good. I was working for an electronic health record vendor, and we were kind of creating some content as a starter set for people, and we created a 4-month checkup form. So again, pediatrics, that's important to me. 4-month-old, and we were able to make this form. This was just one of the options on the form to say, like, hey, only show this for certain patients. Only make this form available for certain patients. And why would you want to do that? Well, instead, if I start searching for forms and I've got a 1-year-old in front of me, I don't need to see the 4-month-old form. It's just going to add visual garbage and make me do some more work. I don't want to have to do it. And so I said, okay, unless the child is between 3 months and 5 months old, do not show this form. Doesn't exist. Well, that's brilliant for 95% of the use cases. But every now and then, a child would come who's a 6-month-old who maybe never had a 4-month checkup. And the doctor wants to use both forms or take some aspects of, I've forgotten what are the questions I'm supposed to ask for a 4-month-old. Let me go look that up in the 4-month visit. It doesn't exist because they have a 6-month-old in front of them. And I was trying to be smart. And what in fact I was doing was making the system less predictable. The doctor expected to see a 6-month form, no matter what the age of it should be able to select and find a 6-month form, maybe not in their face or on a silver platter, but they should be able to search for it. They weren't able to search for it. That was considered a bug to them, reasonably so. And so adding as much kind of predictability and transparency, to me, it's similar to when you go to an elevator bank and you press the button to call the elevator. Boy, it's so nice if there's a little light that goes on when you press the button, right? Because I now know I don't need to press that button anymore. And if I walk up and someone's waiting at the elevator and I see the down arrow is already lit up, I know I don't have to go press it or interrogate the person that's standing there. Did you press it? Did you press it right? Did you press it hard enough? Sometimes you have to press it a couple times. That like aspect of transparency are things I think we should add more in life. Just a few more things, a few more chapters. The fifth one: listen to your users, and that again seems pretty simple. Listen to your users. Of course, you should do that, but it's actually much more complicated because of two things. One is you have to find the right user, the right group of users, and then two, sometimes you have to ignore them. And so, what do I mean? I kind of alluded to this at the beginning. The cardiologist, if we're going to be putting in a new cardiology workflow or new cardiology module or some new technology for cardiologists, and there are questions about how it should be configured and set up, oftentimes vendors and IT folks want to go to the boss, go to the head of cardiology. They're the boss. They've been doing it the longest. They're the smartest. And you ask that person, and they will undoubtedly give you the answers. They will tell you because they're in a position of giving answers to when people ask questions. The problem is that they probably are not the target audience. If they're in charge, they probably barely do the work because they're mostly administrators and they mostly manage. And when they do the work, meaning seeing patients and and doing that sort of stuff, they often have a group of people around them to do the dirty work. They're not putting in their own orders. They're not actually interacting with the electronic health record very often in a senior position like that. And they're the last person that I'd want to know. I'd really want to talk to someone that is in mid-career, someone who's really doing the work, who spends time in the tool, and who can give me great feedback. And then, as I mentioned, also sometimes your end users, when you ask them how it should work, they and I'm guilty of this as anyone else. The answer ultimately can be boiled down to exactly how the tool I use now works. Well, why? Do you like that tool? No, but I understand it, and I've formed muscle memory around it, and it makes sense to me, and I want it to work just like that. And sometimes that's good information. Often that's bad information because again, all we're doing is repeating the mistakes of yesteryear. And I again, I see this sometimes in apps on the phone. We're all at the point now where our apps just update overnight. We don't actually go and seek that. And most of the time, we have no clue that they updated. Every now and then, they look completely different. And no one told us anything and no one asked us anything. And I don't know how to use it. And I know before I would click at the top and then the bottom and then over here. And now I don't really know where to click. And I hate this. And this is horrible. And I want to go back to the previous version, but I don't know how to and I can't. And I will complain and yell and scream. And then someone may come to me 2 weeks later and they say, "Hey, what about that app you're using?" And I'm like, "Oh yeah, it's fine." "Yeah, but we changed it and you hated it. And you said, you wanted to go back to the previous version. So tell us, like, do you like it?" And the vast majority of us are like, "Yeah, I have no idea what you're even talking about. I can't remember 2 weeks ago. I've relearned, I've put in that effort to get that muscle memory to kind of rework, not because I wanted to, but because I had to. And now maybe it's even better, but it's certainly not worse usually than it was. It's just different. And I don't want to do that work. And so if you ask people, would it be okay to do it this way? There's some benefits. oftentimes, no, I don't want that. I just like it the way it is. Um, that's probably the wrong answer. And so just because someone says it doesn't mean you as a designer or as a IT person or as a senior leader in the organization, that's good feedback, but it doesn't necessarily mean that you should take it. And finally, adopting that continuous improvement mindset. Um, it's easy to say, it's kind of hard to do, especially senior, C-suite folks are very good at, hey, we just spent $2 million on this new product. It's live. We're done. I'm so excited. Now we can spend money on other things. And well, that's true. You've just turned this thing on. It was very expensive to turn on and to configure. Um, you got it wrong a lot of what you did is wrong. And my attitude has always been, when people say, should we do this A or B? Which one do you think you should do? And I often will give them an answer, but I say, but there's an excellent chance this is not the right answer. And we'll do everything we can to get the right answer. We'll see what the vendor recommends, and we'll see what other people have done and other organizations have done. We should do all of those things. But sometimes it's the wrong answer, and you're not going to know until you are using it. And so kind of going in with that idea that you're going to be wrong often, and you can't just leave it, because we're really good at leaving it. You're going to have to go back in 3 months or 6 months or a year or sometime and say, okay, what kind of feedback are we still getting, and can we fix it? Again, when you first turn something on, you're going to get lots of complaints. Many of them are not valid because they're just like, I don't like this. This is different. I have no muscle memory. I'm expending work. You've added friction. All of those things are true, but I need you to get through it and then talk to me afterwards. And so when you get to that afterwards phase, maybe that's 3 months. I don't know what that time is, but that's where you're like, okay, now tell me. Now tell me what's wrong, because your feedback now, after using it for 3 months or 3 weeks or whatever that time frame is much more helpful. Because if it's still bothering you, it's probably a defect and we need to fix it. But if it's bothering you a week later, I need you to get a little bit more comfortable with the software, and then, or the tool or whatever, or the workflow. And then it's going to be a little easier. Whew, that's a lot. So those are 6 things.
Yeah,
Um, there will
it's
be a
fantastic.
quiz, Owen. There will be a
On
quiz.
the end to make sure I was listening, which I absolutely was.
No, no, for you. You'll be
Uh,
taking it
oh, okay,
during the
good.
podcast
Yeah,
to
indeed.
see. Yeah. Because it looked like you had left and went out and got a tea and then came back.
I was still present throughout
Were
the
you?
whole
Okay.
thing,
All
the whole
right.
thing. This is fascinating, Craig, for a number of reasons. One is that electronic patient report forms have just become a reality in healthcare, from pre-hospital care to emergency departments to surgery to pediatrics to general medical wards, to general practice. It's electronic patient report forms and patient flow input of data has become every clinician's reality. And to your point, and as you were saying, it is disruptive. It's a lot of change, and there is a certain amount of resilience to that change when it's a massive change in workflow, and it's a massive change in the way we input data. And it does take time, like you say, to iterate. And I think those six points are absolutely key. And the last one is fundamental, this continuous improvement and iteration. And it kind of leads me on to my next question nicely, which is, and my reality within hospital care was certainly around critical care. And you have a dying patient in front of you. The last thing I actually need to be doing in that moment is inputting data, or it's not necessarily a last thing, but it's something I you need to get on and assess and then treat the patient quite quickly. But my question really, Craig, is around how can we, even in those moments, and you with a sick child, a sick pediatric, who actually just needs that high flow oxygen or needs that nebulizer or whatever, how can we enable technology to benefit or enable us rather than disable us in those moments as well, where because I'm hugely interested in how we interact with technology to cross-check drug dosages,
Yep.
that it is the right drug, that actually the differentials are clearly mapped out, that the technology is enabling you to treat promptly when you need to. Could you maybe speak to those enablements and indeed disablements?
Yeah. In the book, we call this an off ramp, that you need the ability to have an off ramp when something unusual is happening. And so you got a perfect example. Another would be like a code, you know, a patient's heart stops in the emergency department. And that is not the time to be double checking everything and, you know, making sure the doctor enters orders. Same thing in a pre-hospital setting. You know, if you're doing CPR, the vitals are less important. CPR or entering information. And so one of the problems that we used to have, and probably still have to some extent, but it was much more prominent. There was a one EHR vendor had their software configured at a major children's hospital. This is back in the early 2000s, and they noticed a significant increase in mortality in their pediatric ICU after introduction of their electronic health record, and kind of trying to do an analysis and figure out what happened. It was pretty obvious. They put in a bunch of checks to make sure that everyone was doing everything right. And so one of those checks was to make sure that they had a wait on the patient before they accepted medication orders, right? And children, many medications are based on weight, and if you don't have an accurate weight, also if you don't have an understanding of their allergies, their drug allergies, then it's probably a good idea to not put in or allow people to put in medications, right? I get that. Well, this is a big children's hospital, it's a tertiary or quaternary center. They were getting referrals of patients from other hospitals, sometimes by ambulance, sometimes by air ambulance. And what had happened in the past on paper was the residents would start writing orders based on what they understood was happening, so that those could go down to the pharmacy or wherever the pharmacy was located, and they could send back up, bags of meds that were ready to go. And even though they didn't have all the details, they thought they were going to need some of this. Well, with the introduction of the electronic health record at that time, that was not allowed, and there was no off ramp. So what that meant was they had to wait till the patient showed. They had to get a wait on the patient. They had to find, if the paramedics knew if the patient had any allergies, put that into the computer. Then they could order. Then there's a necessary, whatever, 4 minutes, 5 minutes, 6 minutes delay of those medications coming there. And the patients did not do as well. Totally understandable. There was no off ramp. So that makes sense for 95, 97, 99% of patients to have those kinds of hard stops where you can't go any further. But that makes no sense in a healthcare setting to not allow professionals to have kind of an off ramp for them to be able to say, like, okay, I understand most of the time, but I'm waving my hand and going like, yeah, I'm not following the rules on this one. The similar stories I tell physicians, or when I tell like safety folks, patient safety things, like, well, we can never have a doctor, write an order for this. And I say over and over, like, the doctor could write an order in my very expensive electronic health record for the nurse to hold the patient outside the window by his ankle. Like, I gave the doctor that ability. It's called a nursing communication order, to type whatever they want to type in, right? And I give them the opportunity to override anything that they want to override, because sometimes maybe it's 1 in a million. But what you consider an overdose, some pediatric cardiologist considers the appropriate dose, because this is a 1 in a million patient. And I don't know what those are, but I do need, though, from a patient safety perspective, I have multiple backups, and that Swiss cheese model, right? So I have, for the case of the doctor ordering the patient to be held outside the window, good luck with your nurse doing that. Hopefully your nurse won't do that. If the pharmacy gets an order for a medication that seems toxic, I would expect that a licensed pharmacist is going to question that and look it up and go, oh, I see, for this patient, yes, or I don't understand, I'm going to talk to the doctor before I dispense this. And so same thing, for a medic who's going to be working out in the field. You have to have those kind of off ramps from the technology to be able to say, forget you, buddy. Like, I'm not putting in the weight before I can get an EKG. Like, you have to give me the opportunity to do some of this stuff, going outside of the rules, trusting me that I'm able to, I have the professionalism and experience to be able to do that. And otherwise, we'll treat you like a kindergartner. And and believe you me, there's a lot of times, especially physicians, need to be treated like a kindergartner. I'm all for that when it's appropriate, but it's not appropriate often, you know?
Yeah, absolutely, Craig. Absolutely. And I think you make a fantastic point and that is that there is atypical moments within healthcare, sometimes not infrequently, whereby, like you said, 9 times out of 10, the pathology is subacute. It's not, it doesn't need immediate treatment, and you can engage with that technology. But there's that 1 out of 10 times that actually you need to act within a certain time frame to prevent mortality, and actually the enablement of IT, or like I said, the off ramp from that IT is absolutely key, so that you can expedite treatments, and sort of prevent these workarounds, really. Because I think what I see a lot of is workarounds where there is clinicians try to maneuver technology to fit their purposes, rather than the technology serving them, or shoehorning them, or guiding them into the right decisions, or indeed the right workflow. And actually those workarounds need to be addressed actually within the continual improvement framework, because there's a workaround for a reason. And to your earlier point, we need to be mindful of those workarounds, and how can we adapt because this is now a trend, and most clinicians are now doing this workaround to try and avoid this, whatever the process is. But then how can we adapt and change the IT to serve and indeed make that workaround more appropriate, and integrate it within the workflow.
Yeah, then it's not called a workaround, it's called workflow.
Yeah.
Workaround is when you don't follow the recommended workflow. And to your point, sometimes that's because the workflow is bad. Um, let's have the physician enter, hey, I ordered an X-ray. Let's have the physician tell us if the patient's pregnant or not. Okay, but they're not the if they know, okay, but like, that's really not their role to tell you. You don't need to go to medical school to figure out if someone's pregnant or not. Like, all you're gonna do is ask the patient. The tech can do that. And so if people are kind of working around that, to me, that's the problem. The problem is not that, the problem is not the workflow. I'm sorry, the problem is the technology. It's that we haven't really thought it through. But we do need these kind of abilities to kind of get off of the prescribed path. Verbal orders is another example, both pre-hospital and in the hospital. We give the doctor ability to just say, like, oh no, don't type that into the computer, just yell that out. Code is an excellent example of, I'm not going to go to the computer while I'm doing chest compressions.
Yeah.
I'm going to yell out how much lidocaine I need, and someone's going to get me that lidocaine. However, if you and I let me be clear, I've never seen this happen. And when I say that, I mean I've seen this happen all the time. I've seen I've seen physicians, when they say try to give a verbal order to a nurse. This happened a lot in the past, not so much now. But and the nurse is like, well, you're supposed to put that in the computer. And it's not an emergency. No one's dying here. I'm not seeing anyone dying. And they'll walk around the corner and then call. I'm busy now. Now I'm busy. Now will you take a verbal order? Like, okay, you're abusing the off ramp we gave you. And sometimes when I'm like the chief medical information officer, I'm the the head honcho with regard to IT. People say, hey, will you go talk with this physician? And I've actually refused on a number of occasions and said, this physician fully understands how to use the software. All the other physicians are using the software the way that it's intended. He doesn't, and I say he because it's almost always a he doesn't want to do it. It's not that he doesn't understand how to do it. So I need the chief medical officer to come with me, because that's a different conversation than me having that conversation. But yeah, to your point, there's, if everyone's doing it, chances are it's not abuse, it's bad design, or poor decision making on behalf of the leaders who said, we want it to be done this way, and common sense be damned.
So, Craig, as we come into land, just finally, I just like to say it is a fantastic book. I'm hugely interested in human factors workflow, and you mentioned the Swiss cheese model, and I think that's such a fundamental model within healthcare. It's a seminal model, really, within healthcare around these latent failures and active failures. And it really, the book denotes that, speaks to it, and it's this is a fascinating book for anyone in healthcare. Actually, could you maybe leave listeners with just one or two take-home points before we finish?
Yeah, I think but we're not going to have time for the quiz, which I'm really a
Damn
little
it!
sad about
Gosh,
that,
that's a
Owen.
shame.
But I'll work on that. I think and thank you for the remarks about the book. We tried to write it. I tell people we tried to write it for senior leaders, which means we dumbed it down a little bit. And I think the main take home message is you don't have to be scared of that concept of design. No one's asking you to figure out what colors go together. No one's asking you to be an expert in the way humans think. You're not going to be a human factors engineer after reading the book. But I think it's the concept of intentionality, right? You need to know that when you do these things, when you design, and even if you say I've never designed anything in my life, you've 100% designed thing. Have you told people how to do something ever? Then you designed that. Is to try to be intentional about the way that you're doing it. And so just thinking about some of these big picture recommendations, and then intentionally kind of going through your head saying, okay, did we achieve the outcomes we wanted to achieve? Did we make it? Did we decide what the right thing is? Do we make it easy to do that? Right? Did we get rid of some stupid things that were automatically in there, or those kinds of things? That intention is the place where most people kind of just slip up, and they don't think about it as they're doing it, and then they have to go back if it's not successful or not as successful as they want. They have to go back and think about it again, and that's kind of redoing the work. So I think the one major kind of key is just intentionality. Will help you not, I don't want to say do it right the first time, but not do it as wrong as you might have the first time. Because again, with from the continuous improvement concept of you, no matter what you do, it's kind of be wrong. Your chances are excellent of being wrong, but let's not make dumb mistakes. Let's make good mistakes that we couldn't have predicted, and not things that were like, oh, I didn't realize that humans like to do the same thing this way. Like, okay, yes, you should have intentionally thought about that and applied that. So that would be the big thing. And then I'll put a little tiny thing. The second minor point, if I'm talking to any healthcare system leaders, is to tell them that they have people in their organization who are much smarter than they are and than I am about design and human factors. Find those people, empower those people to make decisions, to overrule your chief of cardiology and yourself, CEO, because they probably know more. They definitely know more than you do, and are often going to make the right recommendation. So kind of finding them, empowering them, and allowing them to do their job, everyone's life will be better.
Great, that's fantastic, and that's a fantastic place to end. And like you said, fundamentally, it's about safer patient care. And just one of the points you just made just there, which is absolutely key, coming back to the end user work. This working backwards principle, where you're just getting to the people which are actually using the system, and it's not the CEO, it's not the COO, it's just, and it's not, it's getting to the grassroots people that are struggling and or thriving with the tools. Craig, listen, I want to just thank you for your time today, but also what we'll do is put links in the show notes to the book. It's a fantastic read, and I do advocate that people do check it out. But thank you, Craig, for your time.
Thank you so much. It was a pleasure.